Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Welcome back, everyone, to Talk Dizzy to Me. My name is Dr. Abby Ross. I'm a vestibular physical therapist and neuroclinical specialist, joined by Dr. Danielle Tolman, also a vestibular physical therapist. And today we have a guest on the show. I'm going to call her the concussion queen at this point because I saw her present at the Midwest Vestibular Symposium this year, and there's just no better fitting title for Dr. Becky Bliss, also a physical therapist, but she has so much knowledge in concussion. And before we bring her onto the show and have her tell us a little bit about herself, I want to shout out Vestibular First for these cool shirts they sent Danny and I. It says semicircular interpreter, and I could not be more obsessed. So thank you to Patrick and Helena for the cute gifts. I'm pretty sure they're going to be selling these if they're not already. So if you like them, hit up Vestibular First and get you one. Becky, thank you so much for joining us. Tell our audience a little bit about your background. What got you into the concussion space?
Thanks, Abby. Thanks, Danielle. Great to be here. So it's kind of funny now that all of the trajectory of like where I am today got me here. But back in the beginning, I was a PT for about 5 years. So I call myself like a newbie, right? Like a baby PT. And I was working down in Fayetteville, North Carolina. Where, if anyone is familiar, that is where Fort Bragg, one of the larger military posts in the United States. And this was in the early 2000s when Operation Iraqi and Enduring Freedom was happening. And I, at that point in time, as a new grad, you could rotate every 6 months. So they were an 800-bed acute care hospital. They had a 70-bed IPR. They had 5 outpatient clinics, a wound care center, a neuro center, peds, like you name it, LTAC. And so I was getting ready to come off of acute care in the neurosurgical ICUs. And I was like, I think I want to, try some time in neuro outpatient, knowing that they saw a lot of patients with vestibular disorders and I had no training. So I was doing some shadowing and I literally rotated. And the next week, Fort Bragg came to us because at that point in time, they had nobody on post except for one person who did vestibular therapy. And they were getting all of these soldiers returning with the signature injury of war of concussion, sometimes much more than that, but blast injury. And so I went from 0 patients with concussion to 13 new evals the next week after we signed on the dotted line, because we had a multidisciplinary team all under the same roof in our neuro outpatient center at that point. So PT, OT, speech, and neuropsychology. So, and this was back in the early 2000s, right? So we're still trying to have that model, but I was blessed to have that. So I did everything possible. I feel like I learned by assimilation and just diving deep. I bought the Sue Herdman. At that point of time, it was the 3rd edition of the vestibular rehab. And I remember this like small little chapter, right, on TBI. And I was like always referring, you name all the things for differential diagnosis, like I saw it back then, right? Like Valsalva with like semicircular canals and fistulas and sinus, like micro tears because of the overpressures and blast. And I had no idea but to refer out, obviously. And so I started back then in the early 2000s, I still am married to him. That kind of came out funny, but a military flyboy. And so his last duty station was out here in the Midwest in Kansas City. And so I went from tactical athlete, because I worked with all walks of military, but a lot of the special operators, I was so blessed. They would send them directly to me, which was really great. So I ended up doing a lot of support group and teaching for USASOC down in Florida and some other things that I actually still have that relationship. I'm so lucky. But then we moved out to the Midwest and there's no deploying units really. It's a military police unit. So there's not a lot of blast. And so I just transitioned to sport-related concussion once I got here. And I've been, doing it ever since. Now I get to teach it, nationally I get to teach it. I teach it in the residency. So I'm full-time faculty at the University of Kansas Medical Center, but then I also still clinically practice about 4 to 8 hours a week. So I get all the VIP patients So I get to see high school athletes, SEC D1 athletes, like you name it. And then I also am the program coordinator for the University of Missouri's Neuro Residency program. So yes, I still live in Columbia, Missouri, but I teach for KU because they just launched a hybrid entry-level pathway.
That is amazing. I mean, that resume is something to be very envious about, and especially having that experience, being in a multidisciplinary clinic like that is just invaluable. What you take away from that really kind of sets the tone and kind of gets you headed to a path that you really enjoy, which is great. Now, concussion can be like kind of that buzzword for some clinicians, like a vestibular. It kind of gets into this anxiety producing thing as a clinician, like, oh my God, what do I do with this? Because it is very individualized. It's very different. It's a range of different types of presentation. So why don't we start with just defining what exactly is a concussion?
Absolutely. The definition's changed. I don't know if people have stayed up to date. Like we've gone, like if we think about some of the seminal publications out there and white papers, like the Consensus in Sport group, which goes way back. And then they've got their most updated 6 consensus statement publication that is out there. And it is defined as, right, an impact to the head, body, something that produces an external force that causes, right, the brain to be injured. It does not need to be a direct blow to the head, although it could. It can go to the body. If you think about motor vehicle accident and a whiplash like rear ending, obviously that could be something as well where the head doesn't impact anything, but it just kind of shears because of the acceleration, deceleration. American Council of Rehab Medicine, ACRM. I had so many acronyms in my brain right there. Just actually published their new definition and diagnostic criteria. So there's a kind of a decision-making tree based on signs and symptoms of different criteria as well. So if people aren't like familiar with that new publication, it kind of helps get the muddiness. Then that is just like symptom, like, well, the patient reports this, right? Or they're reporting these symptoms. Is it a concussion? Is it something else? You know, that's always something that comes up with my athletic training friends that are on the sidelines, because if these athletes have been playing, you know, for an hour plus and they're like exhausted, maybe it's heat exertion. Some of the symptoms as they come off are very similar to concussion. So it makes it a little muddy. So we're trying to improve that diagnostic criteria, the objective measures. Things have changed so much in the last 10 to 15 years. And my goal is to translate and keep everybody up to date so that these patients don't suffer. And I think that's the biggest thing. You mentioned how like complex and anxiety provoking, because there's so many things that could go wrong with these patients, or like the signs and symptoms that they present with. If you think about the clinical trajectory model, you know, is it the neck? Is it a post-traumatic migraine? Is it vestibular? Is it ocular? Is it cognitive fatigue? Is it anxiety mood? Like, what are all the things that could be contributing, which makes it pretty scary. And that's what we found. I have a great colleague, you all probably know her, Ann Galgan from Philadelphia. We published a qualitative study last year that looked at experienced clinicians and their clinical decision-making regarding patients with concussion. And it is really great because, one, it blends my educational background with my concussion, and we like came together because it was the clinical reasoning, but it really showed how experienced clinicians just had this like cyclical thought process when working with patients that, you know, just automatically happen because of pattern recognition, versus novice clinicians who are like super pumped and then they get fearful because it's so overwhelming. And so my goal is to really make it not overwhelming, give people a systematic way to approach these patients, but then also elevate care, because most of the patients that I see aren't the easy ones anymore. I get all of the like, hey, Becky, could you see this patient? And it's the 3rd round of therapy that hasn't gone well. And now they're so affected by maladaptive strategies. Their brain structures even think like, I'm going to live with this forever, when they don't have to be. So yeah.
I can feel your passion coming through your screen right now, and it's getting me excited. I don't even know which direction I want to go in. But you mentioned one thing I want to make sure the audience is clear on. You do not need to physically hit your head to sustain a concussion. But the other thing I want to make really clear is, do you need to lose consciousness to sustain a concussion?
No, absolutely not. So those are some of the old school ways of thought, right, of diagnostic criteria versus not. And then if you think about, I was just having this conversation with a concussion neurologist at KU yesterday. We had a research meeting, and the frustration from him is that by the time the patients get to specialty referral, they've been given misinformation at, PCP or PEDS or urgent care or ED by nobody's fault, that it's really hard to stay up to date with all the changing concussion literature, research, evidence, how we should manage these patients. And if you actually look at med school, the amount that they like, if you think about what they get for concussion, so unless they're seeking or they're in the sports medicine world, they may not have had the advanced training. And so, if a new publication happens, it takes 17 years to translate to clinical practice. That's our goal, is how do we change cultures and organizations to better serve the patients and not place blame, because that doesn't do anybody any good, right? Well, that person should have known, or they got outdated info, and that doesn't matter, right? How do we actually fix the root cause? Which is, a lot of the times organizational.
And you touched on a lot of the different systems that could be affected by this type of presentation. What about symptoms? What are these patients coming into your office complaining of?
It varies, and I think I've heard everything. So this might be a long list. So the varying of, we'll start like headache is number one, dizziness, fogginess. Sometimes the individual tells me, like, it feels like I'm coming through spider webs. I have a sports medicine physician I work with who is literally like, I can't define foggy. It's different for everybody, but our patients post-concussion say foggy, right? Double vision, blurry vision. Sometimes you can get some true vertigo, which could be post-traumatic BPPV, or depending on the mechanism of injury, do they take a blow or a baseball or a soccer ball directly to the temporal bone? Then they may also have a unilateral peripheral loss that's immediate. Impaired gait, ataxia. Sometimes you can get the migraine feeling, cognitive slowing down, sleepiness, change in mood. So if it's something that is not typical, I remember I had early on a mom tell me about her 12-year-old who, he was fine afterwards. And then we got home and he was taking off his cleats and the dog stole his sock and he started sobbing. Right. So this emotional ability that is not normal. And she's like, I knew something was wrong then. Right. Like normally he would play tug of war with the dog and now he's sobbing. And I think that was brought to light. And I'm not sure if either of you are familiar with Luke Kuechly from the Carolina Panthers. When he had a concussion, this was before the blue tent, right, where everything was being filmed. And like he had emotional breakdown afterwards, after he had trauma, and he was being carted off. And that really rose the awareness that's about some of these symptoms that are often, not understood very, very well. So
those are very vast and symptoms that can come also with just plain old vestibular dysfunction. And, it does feel a little overwhelming, but it's good to know that you can have multiple different types of symptoms and different presentations and still fall under this criteria for concussion. You had mentioned a couple of times about how our understanding of concussion and our clinical practice guidelines have changed over the years. What are some of the biggest ones that have become outdated or changed recently?
Absolutely. I think the concussion in sport group, probably there, back in 2013, there was 4 R's, then there was 11, and now there's, I think, 14. So every time that they get together and they do systematic reviews and meta-analysis for like what is actually now recommended. It used to be cocoon therapy. You're not allowed to do anything until you're completely 100% symptom free. That is completely wrong now. It is 24 to 48 hours of relative rest. And I still think people get confused by that. Don't do anything, stay at home. But actually, relative rest means don't exert yourself. Please engage in your normal daily activities, like sit at the table with your family and converse cognitively during meals. You can still go outside in the bright light. You can still watch TV, but if your symptoms increase, you may need to take a break. And the big thing about the symptoms is it's not the first sign of the first symptom. And I think that's something that we see a lot of our chronic patients who think, oh gosh, I just had an increase in headache. I need to stop what I'm doing. And then what does it tell the brain? symptoms are bad, that is bad. And then you get this fear avoidance cycle with your patients. And so if there was a great podcast, John Letty gave it for British Journal of Sports Medicine on like how to address this with patients now with the new consensus statement, that they can go, 0 to 2 above their baseline threshold. So like, let's say somebody started with a headache of a 5. If they go on a walk or if they go to school, they can have an increase in those symptoms, right? Up to 2. And I'm a little more aggressive, so I let them go 2 to 3. Abby's laughing because she knows that I'm a little more aggressive from my presentation. But I let them go 2 to 3 above their baseline so that they're not telling their brain that like these increase in symptoms are bad. So you don't have to like stop everything. And I think that, we didn't know enough back then. There wasn't enough research to guide us. We had no earthly idea, were we causing more brain injury because of the metabolic cascade and the neuroinflammation and those things or not? And we now know we are not doing that. I'm not sure if either of you, he was the original author on the concussion CPG, the APTA concussion CPG, Bara Al-Hassin. And I was at he's one of my mentors. He's phenomenal. But I was at a conference that he presented at, and it was the most aha moment for me, 10 or 15 years ago. He goes, we take somebody with a severe TBI in the ICU, status post cradiotomy, and who do we order? PT to do what? Mobilize, get them up while monitoring, right? And now we take a mild TBI and we're putting kid gloves and cocooning them. That makes no sense, right? Historical perspective. And so I always, if I'm around individuals that have maybe some outdated, thoughts, I always give them that analogy because you're like, oh, this makes so much sense. But people are fearful and new clinicians are fearful. It's the brain, right? So how do we, debunk and demystify that for them?
And I can't imagine being on the patient side and having a concussion back then with relatively little information available on the internet. Now, thank goodness, there's people like you putting out information all the time about this, but it's really beautiful to see how far our practice has come in managing patients like this and helping them succeed and get back to improved quality of life. When we think about PT, I love what that aha moment that you spoke about. I had never thought about that. And wow, how crazy, how are we doing that? Or how did we do that? How did no one think, why are we telling patients to do this back then? But when we think about PT, when and why should a PT be involved in care? And can you talk a little bit about the Therapeutic Alliance?
It's like you were reading my mind, Abby, of our qualitative research study with the clinical decision making. So at the core, that was actually one of the themes. The Therapeutic Alliance was a theme from experienced clinicians and how they approach, and that patient-centered care at the center. But then the Therapeutic Alliance was an integral ingredient in successful treatment. So you also asked, so I'll go back now, about the PT role. After sitting next to Rebecca Griffith at the Midwestern, we have a new mission of possibly adding concussion management for PTs in the ED so that these patients can get started early and get the right information. So stay tuned. Her and I might end up doing some things that way. But PT should be involved at all levels. I mean, we really can. If you look at the CPG, right, screening, diagnosis, differential, evaluation, examination, and intervention, right? Those are the, we know that there is literature out there to support. We are part of the multidisciplinary care team, and we can only do so much. People come to us, our 4 walls of our clinics, unless we work in a sports performance center, are not looking like the field. They don't look like the basketball court. So some of my biggest relationships are with local athletic trainers. And it's, every day it's a care team for that. Urgent care would be great. Screening would be great. If you are a SCS and you get to do sidelines and work with, athletic teams, for sure. Absolutely. Acute assessment. Myself, I only do it if I'm hey, Becky, my son plays football and we're at an away game where the AT doesn't travel and the parent's could you take a look at my kid? And I'm well, I can, but I'm not like, I can tell you if I see something, I'll do the VOMs and part of the SCAT6 and I'll make a recommendation. But obviously if you suspect it, they probably shouldn't go back in, especially in high school. But rehab is key. There is emerging at the consensus statement. There was like around the 10-day mark, if patients are still having symptoms or clients are still having symptoms, they should be referred to rehab. I was just at the Consensus in Sport Group conference in Milwaukee several weeks ago. And literally they spoke about like 5 days might be the sweet spot. And so if they're still experiencing symptoms at 5 days, especially if they are in one of the protracted recovery kind of bubbles where they have a history, past medical history of anxiety, mood, headaches, those types of things, then they probably should be referred sooner rather than later because of the maladaptive strategies, the fear avoidance behaviors, and the reassurance that we can provide. We don't need to see everybody. I think that, some people, especially when they're, I want to grow a concussion program, and they get all excited and do you think about it? You don't need to see everybody, but how do you get the people that would benefit the best early to you? And then really make gains. So we did, you didn't ask this, but we changed our practice at the University of Missouri healthcare system. We did a whole knowledge translation project. I walked into the neuro clinic here that's multidisciplinary. So I was very excited. We're all under the same roof. And they literally said to me, Becky, you can have all the concussions if you like this. We don't want them anymore. And I was like, what is happening? Why don't you like them? So we literally did a survey of all rehab professionals, over 146, on their confidence and satisfaction with treatment of different parts of screening, evaluation, intervention, and patient education. And they were not comfortable at all. And then we did retrospective chart reviews, digging in the data to see what was composed of physical therapy evaluations. So what did that look like? And it was because they weren't educated, knowledge wasn't translated. They weren't familiar with the most recent CPG. And so if they came in and they had dizziness, it's a neuro clinic. What are they going to look at? Vestibular ocular. And that's all they looked at. They didn't look at the neck. They didn't look at exertion. They didn't look at the anxiety component. So these patients were in the hamster wheel forever, plus referrals. It was taking them 6 months to get in. Everybody was miserable. The patients, the therapists, you name it. And so we did educational intervention. We knowledge translated. We actually have this published as well, and changed practice. Now we see over 350 concussions a year. Our average length of time to get into the clinic is 2 weeks instead of 6 months. And our average treatment time is about 4 weeks, plus or minus 2 on either side, depending, the complexity of the patient. So.
Wow, that's awesome. And not only are the patients and clinicians at a certain point miserable, but by that time, the patients are so maladaptive. It's where do you even begin? So I'm going to paint a picture now. We're going to get into more of the evaluation, but I'm going to paint a picture of a patient or patients that I typically saw back when I started my concussion career. And they would come into the office, they'd have a hat on, they'd have sunglasses on, they'd be guarded, they'd be walking very slowly, very cautiously, and it's intimidating as a provider. Where do I begin? How do I even get this patient to talk to me? Because they already look like, one, they don't want to be here, and two, I need to also get them moving. Where do I start?
That's every, so not so much anymore because we're getting them sooner. So I have to say, but 2 years ago, that was it. I can remember this young athlete in high school who came, same thing, sunglasses, right? Hat, slowly walking. I was like, hey buddy, we got to take the hat and the sunglasses off. I need to look at your eyes. You know what I mean? And some of the tests that we're going to do. And he looked at me and I was like, but it's that therapeutic alliance, which is what you asked me and I never got to, but we'll get to it now. I start with just subjective, asking them, tell me about stuff. And then because of clinical experience, I think you can also infer hey, are you having any trouble? And then based on their subjective, and then link it to function. And then they're yes, how did you know that? Right. And so when that happens, they start to relax. when you're explaining the why they're having their symptoms, that this is very normal. You're providing education and reassurance. You can almost see that like guarding go, right? Like they relax. It was very funny with that specific patient with his little sunglasses and hat. He got the hat off, but he wouldn't take the sunglasses. And I was like, buddy, I need to see your eyeballs. Like this, I can't do a thorough eval to really be able to address things unless I can see them. Like, let's take them off and see how we do. And then, he's like kind of squinting, and I was like, but I started asking him about football. He was a football player. And the minute he was distracted, we were all good. Right. So, but a lot of it is that reassurance therapy. And educating, and they don't get that information, maybe depending on the path that they took to get to you. Maybe, ED didn't like give them all the information about current practice. I also spend time to say, like, tell me what you already know, or what have you been told for either recommendations or maybe other people's experiences. And then I'm able to use evidence, like in a health literate way, to say, well, actually, there's these great new studies that show that active, right? And I'll just go into some of that to build their therapeutic alliance as well. So, but those patients, I'm like, bring them on. Like, those are my bread and butter. I love those because there's such huge gains when you can actually build the trust. And then the art of distraction, right? Of they don't even realize they're having symptoms because of the rehab that you're giving is very functional and salient and based on principles of neuroplasticity. And I like to give the example of somebody's got like a saccade problem, right? You test saccades, or you do the ADEM, which is one of the objective measures that we use in our practice to look at ratios and speeds of voluntary saccades while reading. And then we see that and we're like, oh, we have to work on saccades. So how do I do that? I have them actually now look at 2 targets. And I'm so like, I used to be that person too. And I was like, absolutely, let's do that. And now it's like, don't do that. And I'm going to tell you why, is because vision is automatic. Like, I'm looking between both of you on my screen, but I'm not thinking about moving my eyeballs. My brain's doing it naturally. It's an automatic reflex, right? Automatic subconscious thing that we do all day long. And what we do sometimes, because we really want things to be perfect and we want things to be right, like, oh, but it has to be restored to normal. So then we have, have them put 2 targets up on the wall, and we have them now look back and forth and back and forth. Well, now that just took an automatic movement that was subconscious. We made it conscious, we made it cognitive, and we slowed it down. And so by doing that, how much are we now having our patients hyper-focus on their functional eye movements? And we also know there's new literature out there that when there is vision deficits, it's linked to the autonomic nervous system to fight or flight. So now we're adding to that. So I could think back to all the patients and I'm like, oh, I think I made things worse, right? Like, oh gosh, what was I thinking? So now after we build the therapeutic alliance, I immediately am like, you know what? I know you're probably having difficulty in school, right? Like looking down at if they have a convergence or an accommodation issue, like when you're reading notes and then looking up at the teacher and back and forth. And I bet you you might be getting a headache, and they're like, how do you know? I just stopped because it's so bad. And I'm like, okay. And then we can explain the reason why it's happening. But we have to tell the brain there's something wrong in order for it to cortically remap and fix itself, right? So then we dose, but make it more functional activities. And functional activities that they could do throughout the day. You take a 16-year-old kid, there's no way they're looking at heart charts back and forth, right? They're going to be like, what the heck is this, right? So you have to make it fun. I want you to I don't know, look at some YouTube video and then look in the, whatever it happens to be. You have to be creative with them. But so.
I've been enjoying using Spot It. Are you familiar with that game?
Spot It.
Yeah, so it's
visual scanning,
yeah, it's visual. It's all these different. You have 2 cards, and the first person to find the common thing between the 2 cards wins that card. We play with the kiddos. But I've recently been using it in the clinic because they have to kind of look and search on that, and we can do it kind of like a heart chart. It's
you could do it near in front and then have them go, oh my gosh, exactly, so that they're not actually thinking about their eye movements, right? They're scanning automatically in that fast way that they're not thinking about their eye movements because you've added a cognitive challenge.
And it becomes a competition because if the patient can beat you, they feel so good about themselves. Well, kind of looking back at the evaluation portion of it, what are some of the common tests that you'll do at bedside that you do with your concussion evaluations?
Yeah. So ours is when we did the the knowledge translation education, what we realized was the comprehensive eval was not being done. So as physical therapists, based on the CPG and the consensus statement, you should be including a cervical assessment, a vestibular, an ocular, and often those are combined, and a motor function. Motor function, I've got a survey right now. Hopefully, maybe people will take it. But I've got a survey about motor function and how people are assessing that right now. But you have to define that because it's really like, well, what's motor function in relation to concussion? Static balance, dynamic balance, reaction time, and dual tasking. And that's how motor function is defined by the CPG. And then exertional testing. And so I'll usually start with cervical, like range of motion, joint mobility, proprioception, cervical joint proprioception. If you're not doing it, you are missing the boat because that's integrated. You all know this, you're vestibular therapists, right? But like it's integrated, right? The eyes, the ears, and the neck all have to talk. But if you look at Catherine Schneider's like randomized control trial, it's the combination post-concussion that patients do better. The cervical with the vestibular ocular, and it all has to be working and saying the same thing. So cervical joint proprioception is huge. I also add in a smooth pursuit neck torsion test to rule in or out cervicogenic dizziness. It's very, very useful. And most of the patients, that's where you get them and they're like, oh yeah, I can feel it, right? And then you get more buy-in. So it's a more like, how do I get buy-in? Because they actually now feel validated because I have like been able to show that there is deficits when nobody else can see them. I don't do it on first visit, but the deep cervical neck flexor, like endurance tests, really looking at those because there's some literature before they go back to play that those should be strong. And it can help mitigate the severity of injury, not prevention, but severity. So those are super important, especially in anybody returning to recreation or sport. And then the full vestibular ocular exam. I know people that are not vestibular specialists, the VOMS is fantastic. You don't have to be a vestibular specialist. Abby, I think you said like it's anxious thinking about all the things, somebody, or maybe Danielle, it was you, of the vestibular, but that's why they created the VOMS, right? So if you're the orthopedic, like, specialist, or that's what you, or geriatric, you don't have to become a vestibular specialist to treat this. You could do the VOMS, right? And it can tell you some great information or get started. And then if it isn't getting better, then refer, obviously, to somebody who's specialized. One of the big things with the ocular that I take a deeper dive in is accommodation, because that is one of the high, like associated with convergence insufficiency. And it's what we do all day long. We look at our phone, we look up at somebody, we look at our, like whatever that happens to be, the near far, that tends to be a trigger with our patients. And some of it can come from a convergence insufficiency, but other times it's an ocular alignment problem. So I always add in the cover on cover and the alternate cover test. But I can actually see it. I literally have done this for so long. I can see it just looking at my patients before, and then I just confirm. Like it's one of those like pattern recognition, right? A little bit of ptosis, a little bit of eye turn out, and then I just confirm that that's some of their problems that they're having. Motor function, it depends on the age. It depends on their pre-morbid activity level. High ceiling effects in athletes of the FGA, like the high mat, like they might have a 28 out of 30 on initial visit. And then by the time they come back, they're a 30 out of 30. So I don't use that anymore with my younger athletes. I use the dual task tandem gait. So if you're not using it, please use it. It helps predict the subsequent lower extremity injury risk. And we are so blessed at my clinic that we have computerized CBP in the Vertex. So I will do the full SOT and then the limits of stability for the postural reaction time. So those are huge. And then exertion, like pick which one works best, right? Buffalo concussion, treadmill, bike test. There's now a march test for older adults that you are not okay with them getting on a treadmill, or you're doing home healthcare, or you're in a SNF. Like there's a march test now, which is fantastic. And then there's a pediatric treadmill as well. So sorry, that was a lot.
No, that was honestly perfect, because I think you just gave clinicians who are listening a really good starting point and where to begin an assessment with this. My question for you specifically about exertion, are you doing that pretty soon in your evaluation process, or at what point?
That's a great question that I get all the time. We are very super blessed to have a full 60 minutes at our clinic when we see our evaluations. And so I can usually get the exertional test in at the end without any issues, like going through everything. Sometimes if they're, we take a lot with our therapeutic alliance and subjective, I'll do it on the second one, but that doesn't mean I don't start them dosing on a walking program. John Letty's group in 2018 published like the safety and prognostic utility of doing the treadmill test within the first week. So from 1 day to 7 days, and there was no adverse effects. So you can literally get them on the treadmill and do exertional testing 24 hours after injury. So I recommend it. The sooner they're up and moving, the better. His group now, because he is doing it so early and especially, aren't seeing nearly as many vestibular ocular complaints because they're habituating, right? They're getting them moving, they're getting them attenuated, and they haven't been like decompensating. So it's really interesting to see. He's like, yeah, I'm not referring so much to my vestibular therapist anymore. So I don't know if that's a good or a bad thing, right? Depending on business. But no, exertion comes super quick. And if I can't get it in, they are on a walking program. There's actually a really great article about practical management without a treadmill test for patients to kind of monitor and try to build up to 30 continuous minutes before the next time that they come see you. So
that's so interesting, especially that looking at how they're habituating on the treadmill is almost kind of like an incidental or accidental finding. But
that's really all great. The vestibular, and then they're looking around probably in the clinic. And
Absolutely. So when you're working with patients who are very symptomatic and we're educating them, we want to kind of get back to moving. We don't want to put ourselves in that cocoon. What are some tips that you give them to manage their symptoms while they're in between sessions and while they're going through life, feeling the way that they're feeling?
Absolutely. And I think you both know this because you work in vestibular. Personality plays a very large part in how patients experience symptoms. And so if I've got a kiddo who's very symptomatic, but they're type B, it usually works itself out. I don't have to do too much. Their mom may be more worried about their symptoms than they are, right? But a lot of the times, especially if it's taken a long time, they failed at therapy other places, and now they're super symptomatic, and their brain almost has been rewired to be hypervigilant of like symptoms. We use one graded exposure therapy, and it's literally, I also don't say when they walk in the door, how bad is your headache today? Like those words do not come out of my mouth. Instead, I may say, how are you feeling? And then tell me one thing that you could do now that you couldn't do since I saw you last. And so we reframe and change that. But then also if they're super like ANS, fight or flight, which also happens because of the visual system. And think about this, if I know for me, I've had, a vestibular issue and I was like, I am losing control. I'm a type A person. And I'm like, my ANS just wants me to pass out right now because it does not like this. So your patients that are that way and are so fight or flight, grounding works really, really well. So if they're in a busy environment and it's way too much, find a wall, back up against a wall, place yourself against something that is stable for the grounding effect. I know this is kind of a little silly, but just putting pressure on the top of the head to help them know okay, this is where your head is, this is where your neck is, this is where everything is. And I a lot of our patients, and there's new literature now that are chronic, and this isn't everybody, but some of our chronic post-concussive patients actually have an FND overlay. So the functional neurological disorder overlay. And so the external cueing of a sensory weight, so sometimes, right, it'll just be some weight or some a weighted blanket. Sometimes those types of things work really, really well for these patients because it takes the focus off the symptoms and it puts it to that external cue.
That's great. And one of the things that you mentioned, which, if I could go back early in my physical therapy days, I wish I did this more for sure, but I do the same. I'm trying to get the patient to shift their focus from all the negative that they're experiencing to let's talk about even the most seemingly small win that they can possibly come up with and helping them build momentum in their resilience to getting back to life. And that leads us into my next question. What is our role as a therapist in helping someone get to or deciding when the right time is for return to play, return to work, return to whatever?
So I love that you asked that question, because I actually do a case presentation on where I made like a big mistake. And this wasn't like 10 years ago. This was like 3 years ago. It was in 2022, I think. And so, but I was so inside, like, this is so exciting. Look how great you're doing. And I forgot to ask some questions. But we have a huge role. And so I am, super humble, and I will tell you about it so other people can learn. But I had a D1 SEC athlete, soccer player, goalie. This was her fourth concussion. She had had 3 previously. She was a little like anxious. She had a history of anxiety, depression, but managed by meds, was seeing sports psychology, was seeing a regular psychologist. So she was getting, lots of stuff, and she seemed okay. I didn't pick up on like the normal, right? Where she was perseverating on any of her symptoms. She was super excited because I told her she could like start exercising again. So I was her hero because she wasn't allowed to do anything for 3 weeks. And she killed it because of her competitive athletic, just personality. She did amazing, right? So like anything I asked her to do, like within 3 weeks, she was far exceeding everything. I was getting ready to return her to full contact practice. I had taken her through stage 4 of the return to sport protocol. I talked to the athletic trainer. She's doing great. She was already going to practice, but not doing contact drills. And so between the AT and I, we were both like, she's doing great. This is wonderful. She's probably better than she was before, because we had worked on all this dual task cognitive and reaction time. She got back to full contact practice and went into the box, the goalie box, to take some, like to do some defending, and had a complete mental breakdown. And walked off and was like, no, like, I'm too fearful. Like, this puts me, like, I could do it all here in the drills, but back in that environment. And I asked her about, do you want to play? She was a junior, so she had 1 more year. Do you want to play European ball? Do you want, like, what's the goal, like, when you're all done with college? And she said, like, no, I'm going to move back to Colorado. Like, I'm done with, like, I'm here because it's got me, a full scholarship for my education. She was a political science major, 4.0, like, for a D1 athlete. That's awesome. Right. And, but I never asked her about how she felt going back to receiving, like, to actually try to defend, like, these objects that are flying at her face. Right. And so it was way too much. And so she literally, the AT called and was like, Becky, I know she did really well, but I need all your notes because she's going to be medically retired. And I was like, what are you talking about? She did so well. Like, I did everything right. And I missed that piece. I didn't ask her about it. Now, would she have admitted? I don't know. Right. How could I could have put her in virtual reality, right? And had her like watch soccer balls come at her from like a GoPro or something like that. But, it may have taken her being in that situation for her to know that. But to have those conversations early, I actually just also had a sophomore football kid, 6'5", 265, like, football coaches loved him. He literally went to the pediatrician and basically told her, like, I'm really scared to tell my coaches I don't want to play football. And she basically was like, do you want me to just write it? And so it was after a concussion, and she basically was right, no more football, like, for the rest of his career kind of thing. And like, they were all up in arms. And so I ended up getting involved because, like, the AT was like, Becky, I don't think that's right either. And as soon as I talked to him, he was like, my doc only wrote that because I didn't want to play football again. And so and I'm like, okay, well, I think we should be honest with your your sports teams to let you know. But it's having that conversation early. What's your goal? Like, do you want to go back? Are you fearful? And now I not over like focused on it, but I will ask the questions. And there are some really beautiful like anxiety and kinesiophobia scales out there that can be very, very helpful. Of identifying some of the lingering maybe things that we aren't seeing in clinical practice. But it's also our job on the flip side, if they do want to go back, we better be exposing them to everything that they need to do before they return to play. And not just like, if they're a soccer player, oh, they can dribble the ball, it's all good. No, can they dribble the ball? Can they look down? Can they look up? Can they identify other players? Can we have a loud environment, right? Like, how do we up the game to all the things that they need to be able to do to make sure they're okay and they're not like breaking down in motor function. So yeah, rehab's super fun in my clinic.
It sounds like determining when somebody's going to go back is very individualized from case to case, like a lot of our patients that we work with, but not only from the protocol aspect, but also the personal aspect and being sure to that everything is on the same page. Is there anything that can delay recovery or keep somebody from returning to play when expected?
Yeah, absolutely. The post-traumatic migraine definitely can be, like tricky. So if they are a migrainer, like getting whoever managed them before, we're not going to fix their migraines just by coming to therapy. Maybe we will because we'll discover something. That has happened. So, but not typically. And so, if they're a migrainer before and they have a good, neurologist that manages it, like, yeah, you might want to reach out and make sure that like we don't need to tweak anything. Some of the biggest things is sleep and like fueling. So like sleep can be a factor. And if you don't speak about sleep pretty soon, like early on in the care, that could be a lingering thing that they're still like, I just don't feel, right. And other things, anxiety, mood, some of those is definitely like what can prevent them. There is some exertional intolerance stuff too. So like if the autonomic nervous system is involved, they do great, but when they're really high exerted, maybe that's what brings on their symptoms and the dysregulation. So that's why it's so important to start them early, and then ramp them up. And like, no kiddo wants to come in and walk on the treadmill to do their exert, right? You know what I mean? Like, so I don't do any of that. They come in and they do fun things like box jumps. If they have to be like, if they're a basketball player and they have to jump, well, exertion doesn't have to be walking, right? It can be sprinting. It could be suicides. It could be jogging with cognitive and ball. And so like really exposing them to that stuff early. But getting some of your prognostic predictive factors of protracted recovery, like from the get-go, that's actually one of the things in the cyclical process of the experienced clinician. What are patient-related factors and what does the patient bring to the table? Minus the concussion, right? Like take that out and see, and then you put that all together. So that's that clinical reasoning piece where you're putting everything together. In what are really the concussion impairments versus what was pre-existing, what was maladaptive, and what might be some external factors like pressure from coaches or parents that ask them every 5 minutes how their symptoms are, right? Like, so there's so many things. But yeah, I wish you could just like, literally have a manual, but concussions are like snowflakes. No two are the same, right? So that's why I think I'm never bored in clinical practice when I get to be there is like, they're never the same. But there are some, pattern recognitions from that you can pick up on and then like get to early. So
part of the theme I think that you've been talking about throughout this is almost becoming a teammate with your client or patient and really making sure you understand why they're there. Is it to get back to school? Is it to get back to the football field? Is it none of that? They just want to be able to go to a hike when they move back to go on a hike when they move back to Colorado. And I think sometimes as therapists, we miss that a little bit because we're so proud of the work that we've done. And yeah, she can take this soccer ball every which way. She can shuffle side to side. She can dive. She can jump. She can do all the things she needs to do. But sometimes we do miss that one thing that's holding that patient or client back. And you kind of have thrown in challenges throughout this whole talk today. Are there any other challenges to providing optimal concussion care that you can think of?
In the beginning, especially in the first couple of visits, depending on what they have been told. So like if, especially if it comes from, like a physician, like that is known for, concussion care or things like that, but maybe is not 100% like, doesn't want them exercising yet. It's okay. Yet we're at 3 weeks. Okay. This is way too late. Right. So breaking down some of their preconceived notions of what they've been told and have taken because it's coming from a medical provider as like, this is what should be. Now you're telling me to do something different, right? So I think sometimes that can be in the way. Some of the just like hyper focused, like the personality. And I usually like, I don't, you all probably can tell already, like I'm a, let's address the elephant in the room from day one. After I can tell that I've built that therapeutic alliance, we may have like a hard conversation about like, tell me about, like, I can tell that you're, I might actually say like, I can see that you're pretty tense. You've been through the ringer, right? Like some of that I think is just fear because you've had symptoms for 6 months, and I'll build that. But then I'll say, tell me a little bit about like your anxiety, like was anxiety a factor before the concussion? Right? Or was depression, or have you ever suffered from that? Or like, and then we'll talk about it. And then I'll open up the patient education to this really can interfere with progress, right? If not managed well. But you're absolutely right. Teammate, but then I'll take it one step further of like cheerleader. So like literally when I give my educational talks and I have my patient videos in there, I have to mute because I'm like, yes, look at that, right? Like I'm like, or I'm yelling at them because they're not doing it right, right? So, so the cheerleader piece is huge. They need somebody in there, like, to feel like is in their corner, who's advocating for them and their best, you know what I mean? Like best version of themselves. A lot of the times, like I'll see patients that are 1 year, 2 year, 3 year. I saw one, and she's 3 years out. She plays competitive roller derbying. She's a full professor in like, diversity. I mean, she's amazing, right? But she has, because she has like over researched and other things, she's like so focused on all of her symptoms and this like little residual that I bet you if we could externally cue and her not think about, like it would actually get passed. But because she has spent 3 years in this fight or flight, like her hormones have got like the, pituitary axis, like, hypopituitary axis. There's now research out there that when you are under chronic stress for this long, you may have hormonal changes that are now impeding your recovery. So listening and then thinking about the big picture, and oh, by the way, the right age for hormones to change as well, right? So I will make suggestions for them to advocate for themselves in that respect.
I love that. That's such great advice and good knowledge on how to work with these patients. It's amazing. Now, to kind of wrap things up, this might be a really hard question, but what is the one thing that every PT should keep in mind when treating concussion?
That it is a recoverable injury and that you absolutely can recover from it. And I think it's his first name's Stan, and it's Herring, I think, but I could be getting that wrong. He's a sports medicine physician. He spoke at the Consensus in Sport Group like conference that I was at, and that is the biggest thing that we could do as medical providers across all spectrums is because of this, so like the like sensationalism, right, from like our social media, like all of the things that have happened that have provoked maybe some cautiousness and some fear and some other things. The biggest thing we could do for our patients is give them education and reassurance, and I think giving them hope, right? Like actually giving them hope that they may recover. Abby, you saw that in the patient case I presented at the Midwestern, right? Like I even get a little teary just thinking about that because there's so many of those stories that, I'm like the last resort, right? Like it's the third PT, like it's an athlete. They haven't been able to like, and then you're able to see them like return to what they love, right? And I have the same cases, but older adults, right? That, get back to certain things. And so it's giving them hope and reassurance that it is a recoverable injury and that like life is going to be okay again. And that our complex healthcare environment is like messy and sometimes the cause of why they're still having symptoms. But I don't say that all the time.
I think that something I've become more and more used to as I've developed in my own practice. When I was a young clinician, I was so focused on, okay, I need to get all this information. I need to do all these tests. I need to, I only have this amount of time. But one of the most impactful things I think we can do as providers is just talk to our patients. And sometimes that is just about, hey, you can recover from this. Hey, I've treated hundreds of patients that are similar to you who are now doing everything they came in wanting to do beforehand. And we see this not only in concussion, but especially in our patients with 3PD, for example. They've had these symptoms for months. They think there's no hope. They're in support groups where people are, reporting all the negatives, but you don't always see the positives in those support groups because the people that are recovered are out of there. They're done with that support group. And I think that's one of the things I love most about what I do is connect with the patients on a different level than what we would consider physical therapy.
Yeah. And it's putting the heart back in healthcare, right?
Yes, that's good.
Nicole Piamonte is a assistant dean at Creighton Med School. She is absolutely, like, her PhD is in humanities, and she is infusing it in med school. If you've never, like, just on podcasts, literally, like, Google her and listen. She's been on some PT podcasts as well. But it really is taking the moment and having that moment and in talking to your patient, right? When they are suffering and they've suffered for so long, don't get your list out of everything that you're supposed to be doing, but take a moment and acknowledge and be present with them that it does really, stink. If I've got a 16-year-old athlete, I might use a different word, right? But like to build the therapeutic alliance, but this is awful. And I am sorry, right? Like, I'm so sorry that it took you this long to get here. But that doesn't mean that you can't recover or return to things. And taking that moment and having that time with your patient is probably more valuable than anything else that we can do. So,
mic drop right there. You had a couple. Guys, now you see why I introduced her as the concussion queen. Becky, where can our audience find you?
I'm on social media. I'm pretty active. Even though my kids tell me I should not be on Facebook anymore. They tell me that's for old people. But I am on Facebook. I'm on Twitter, or X. I guess I still call it Twitter, but X. Instagram, LinkedIn, you name it. You just have to search my name. I'm pretty transparent about that. Or on the KU website for faculty if they want my email. Please reach out. Absolutely. I love talking and I love empowering others, right? Like, and really advancing their practice and care. Like, I need people to be better than me. Like, that is the whole goal. That's why I teach, both entry level, residency, and post-professionally, right? Like, the world doesn't need more of me. They need people that are better than me out there so that they can make the change. Absolutely.
I love that. And you also have some continuing education that you offer for our clinicians. Where can they find that?
Yeah, that website is just www.blissfullyinbalance.com. So we actually open up. I used to just do like in-person courses, and I never had to advertise because people reach out, so it's great. But since post-COVID, you probably all know this, the CEU budgets are not like they used to be, and it's not recovered, and like the accessibility is really an issue. So I have partnered with Alex Peters and Andrew Terraketter, or TK, from UGA, and the three of us. So we're bringing sports, ortho neuro, and neuro all together, because exactly of what one of you said at the beginning of sometimes, like, the sports ortho is like, oh, it's vestibular, I'm kind of scared. And then you get your solely vestibular, right, therapist that's like, I don't know how to return up to sport. I'm not doing this very well. So we're blending all of our knowledge together, and we're doing an on-demand course in a 3-part series. And so the first foundations is actually launching this Sunday. So it'll be live, super affordable. That's another one of my passions, is how do we translate this without, breaking the bank of people for that. So yeah, we're in the midst of doing that. And then hopefully establishing some communities where people can hop on with cases and just to get some clinical mentorship too.
You mentioned this Sunday. This podcast episode might not air until later, but is this something that they can sign up for at any time, or is it a specific date?
No, so it launches June 1st. How about that? We might need to edit and say it launches June 1st. But they can sign up early or just for more information, and it's open. There's no limit or anything like that. And it's for both physical therapists and athletic trainers to start with.
Perfect. Well, Becky, thank you so much for joining our show today. Audience, thank you as always for being here. Let us know who you want to have on next, what topics you want us to discuss, and we'll see you next time. This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.